Hello, everybody. My name is Brexton Turner. I'm a second-year med student at the Medical College of Wisconsin. I work with Dr. John Gould on this project. This is the first one of my two talks today. I have one at the end of the session dealing with fundoplications as well. So without further ado, this is titled, Is That Floppy Fundoplication Tight Enough? For disclosures, Dr. Gould is a consultant for Thorax/Ethicon, and the rest of us that contributed to the project do not have any relationships or conflicts of interest to disclose. So continuing along with this endoflip subject, so the laparoscopic fundoplication is currently the gold standard for medically refractory gastroesophageal reflux disease, or GERD. Surgeons during a fundoplication seek to create a competent valve at the GEJ, the gastroesophageal junction, that is tight enough to prevent acid from coming back into the stomach, but also floppy or loose enough to minimize side effects of obstruction, such as dysphagia or bloating. Once again, the endoscopic functional luminal imaging probe, or the endoflip, uses impedance splenometry to assess the GEJ intraoperatively, and this device has been shown in many studies to be safe and feasible to use during surgery and can provide real-time feedback intraoperatively on the opening dynamics of the GEJ. So here's another picture of what the endoflip can show us intraoperatively. On the left is the pre-fundoplication. On the right is the post-fundoplication pictures. And as you can see from the top, the esophagus is towards the top, the stomach's at the bottom, and the contour in the middle is where the GEJ is. And comparing the left to the right, you see that following a fundoplication, you have more of an hourglass shape, and in this case, the GEJ decreased in size to give you more of a competent reflex valve here. And so what we wanted to do with this study is similar to the previous talk that was just given. We wanted to determine whether or not endoflip variables that we collected intraoperatively were associated with symptomatic outcomes following the fundoplication. So how do we do this? This was a retrospective review of primary laparoscopic fundoplication patients, including Nissen and Toupet, between 2014 and 2018. Everybody in this study met standard GERD surgery indications, either with esophagitis on endoscopy or a positive pH study. This was done by a single surgeon. We measured the quality of life using a GERD health-related quality of life survey. In this study, we're very interested, particularly in the heartburn, so having them rate their heartburn from a scale of 0 to 5, 0 being asymptomatic and 5 being the worst it can be. Patients were assessed with endoflip pre- and post-fundoplication. We used the 30 milliliter bag volume, and the variables that we collected here were the minimum diameter, or D-min, cross-sectional area, pressure, and extensibility index. The patients included in this study had pre- and post-fundoplication endoflip assessments, as well as survey responses both preoperatively and at some point 6 months following the fundoplication. And so using those survey responses, we divided our population into two cohorts. Number one is the severe heartburn cohort. These are the people that complained of daily or more frequent heartburn at their 6 or more month postoperative survey. And on the other side was the mild or asymptomatic heartburn group, which are people that either had no heartburn or heartburn, but it was less than every day at 6 months postoperatively. For data analysis, we used t-tests and receiver operating characteristic, or ROC curves. So for the demographics in our study, we had a total of 43 patients in the study. The left column is the mild and asymptomatic heartburn group it had an N of 36, which is 84% of our study population. On the right is the severe heartburn group. We had an N of 7 for 16% of our population. And the primary difference between these two cohorts were the age. The severe heartburn group had a significantly younger mean age compared to the other cohort. However, the BMI, the sex, and the procedure breakdown, Nissen versus Toupet, were comparable between the two groups. And so for the results, we used ROC curves to assess whether or not the endoflip variables can predict outcome. And using ROC curves, we asked two questions. The first question was, is there an association between the variables and the outcomes? Or otherwise, can we use endoflip to predict whether or not you're going to land in the severe heartburn group or the mild asymptomatic group? And the second question is, if there is a correlation, what is a good separation point that will help us determine who's going to fall into what bucket? And that's going to give us the maximum specificity and sensitivity. So on the screen here, I have two ROC curves, just to give you some bearings. The y-axis is the sensitivity. The x-axis is the 1 minus specificity. And the way that you evaluate whether or not there's a correlation is you look at the area under the curve. So the solid black line is the curve generated for that variable. And so everything below that, you take the integral of that. An area under the curve of 0.7 or greater is considered statistically significant, and thus suggests that there is a correlation between variable and outcome. So on the left, we have the change in d-min at 30 milliliters, and on the right, we have the change in cross-sectional area at 30 milliliters. And the area under the curve for those were 0.718 and 0.728, respectively. Just for reference, the diagonal dotted line going across the middle is just a marker of what would random chance look like. So if you try to flip a coin, for example, and determine who has an outcome, or to predict the outcome, and that has an area under the curve of 0.5, just to give you a reference. So now that we have established that there's some sort of correlation between these two variables and the outcomes, then we want to look at where along those lines is a good separation point. And so here they are. So the change in d-min, we found that a decrease of less than or equal to 0.15 millimeters was correlated with severe heartburn. Or otherwise, if you take your pre-op value and your post-op value, if it decreases by more than 0.15 millimeters, so 1 millimeter, 2 millimeters, these are going to be your patients that are likely going to have mild or asymptomatic heartburn. On the other side, if it stays the exact same or the d-min increases at all, these are likely to be your patients who experience severe heartburn in the future. And the sensitivity for this value is 71%, specificity is 69%. And then in a similar kind of pathway, the change in cross-sectional area, we found a decrease of less than or equal to 1.5 millimeters squared was correlated with severe heartburn as well. It should be mentioned that the ROC curves for the other two variables that we looked at, the change in pressure and the change in sensibility, had an AUC, an area under the curve, of less than 0.7, and so they did not reach statistical significance in this study. So in terms of limitations, number one is the sample size. We had a pretty limited sample size, especially with the severe heartburn group, which in reality is a good thing, but essentially what this does is it limits the power of the conclusions that we can draw from the study. And the measurements using the endoflip assume radial symmetry and equal pressure throughout the bag of the device while it takes the measurements, which is not always true, especially at anatomic sphincters. So in conclusion, the GEJ opening dynamics attained by endoflip appear to be associated with symptomatic outcomes. When the change in delta min or d-min and cross-sectional area do not decrease by a defined threshold, heartburn is more likely to be problematic at 6 or more months postoperatively. And this conclusion essentially suggests that the fundoplication might not be tight enough. So perhaps go back and make it tighter or consider adjusting the surgery. It should be noted that further pH studies are needed to evaluate the cause of the heartburn in our symptomatic heartburn group. This is a retrospective study, and so that wasn't necessarily available to us at this time. And finally, the main take-home point is that this study demonstrates the endoflip can serve as a valuable intraoperative tool to optimize fundoplication geometry and minimize symptomatic outcomes. So thank you for your time today, and I'll be happy for any questions.